Anshu will start or Bindya, you will start?
I'll start, ma'am. I'm just waiting for 1 minute.
Yeah,
It's
yeah, no.
6:59.
We are also looking for small, blogs. If anyone wants to contribute, we can first assess and then put it on website.
Yeah.
Some interesting cases or some new paper or article. So if anyone wants to put it on the blog, they can message either of us, Bindya ma'am, Aruna ma'am, or myself, and we'll try to put it as a blog on the website.
Yes. So, okay, now it's 7 o'clock and we shall start the session for today. So, good evening, everyone. A warm welcome to the monthly series of the ISCCP webinars. And it's always, as we know, it's 7th of every month for 70 minutes and it's 7 p.m. So, today we have a very, very exciting session on something which is quite unusual, that is the glandular lesions of cervix. And we have our experts for the deliberations. So before that, I would like to invite Dr. Aruna Nigam, our president of the Society of ISCCP, to give her address. Dr. Aruna, over to you.
Okay, thank you, Dr. Bindya. So today again on the 7th at 7 p.m. we all have joined together to work towards the cervical cancer elimination, which is a motto of our society. And we always strive for some innovative topic which can give a lot of information to you all. But before we start, I would like to share few of the informations of the society which we are taking care. So let me share my slides with all of you. I hope it is visible. Slideshow.
Yes, Dr. Aruna.
Okay.
But put it in
So-
slideshow mode.
Yeah.
Now it's fine.
So the first information which I want to pass on is regarding the midterm ISCCP CME. So this is the first time we are doing the midterm ISCCP CME, which AIMS Jammu is conducting in association with many other societies also, Next Generation Cervical Cancer Control from Vaccine to Visualization. And on 25th October in Jammu. So I invite all of you to register for this. The registration is not much, and I would be happy if many of you come to Jammu to attend this CME. So this is a one-day CME from 9 to 5 p.m. along with a workshop. So all the information brochure I have already shared on our group. So you can go through it. And if anybody wants to have some other information, you can contact us. We will share the brochure personally to you also. The next thing which I wanted to share is regarding this HPV vaccination training module, which we have launched 2 months back. And I am happy to share that we have 1,000 registration from all over India regarding this module. And we have trained via this module, around 800 have already completed the module. So I again request to all of you, this is a beautiful module, very insightful module, which you can share among your colleagues, your juniors, your students. It has got 6 small modules of 7 to 10 minutes with the 8 to 10 MCQs, which you have to attempt. If you get 80% of the marks, then you will be certified that you have taken this training by the ISCCP. So I encourage, and this is free of course, you don't need to pay anything for this. This is available, the link to this is available on our website, that is isccp.in. Our website is very much active. All the webinars which are being presented here are put up in that website. You can go back and see or revise the seminar through that our website. The information regarding 2 of the other courses are also there, which you can go through it. If anyone wants to put on something interesting on a blog section, they can connect to Dr. Anshu, who is very active, Dr. Anshu and the Dr. Anjana, who are very active in updating our website. These are the 2 programs or training programs which we are running: fellowship in colposcopy and cervical pathology. It is already running with the 75 trainees. all over India, and the other is a V-Insight module where we have, this is the first time we have launched, and we have 30 candidates who are attending this module. The next session of these two modules will be around in January and or February. So if you want to join, you can take up the next session. And all of you are invited to take the advantage of being an ISCC member. So apply for the ISCCP membership. We are affiliated to IFCPC. So it will be very beneficial to all of you. It is compulsory if you want to take these modules, that is the fellowship module and the V-Insight module, then you need to be a member of the ISCCP. You can do your activities under the banner of ISCCP and take the advantage of the credit points. And I am happy to announce that we have now conducted few of the CME which have been done under the banner of ISCCP, and all of those activities have obtained the credit points also, which have been written on the certificate. But I want to give this disclaimer that these credit points are exclusively given by ISCCP. It has no relationship with the NMC. So these the information regarding the same is already available on the website. It is being updated with all your activities also. Whatever activities you are doing, these are also updated on the website if have been done properly under the banner of ISCCP. So I encourage all of you to do multiple activities so that we can achieve our motto. And with this, I would like to end my small message and hand over the mic to Dr. Bindia to continue with the proceedings of the today.
Okay, thank you so much, Dr. Aruna. And as we all know that please go to Jammu, because next day you can go to Vaishno Devi. And also we are very happy to announce that we have more than 1,000 members now for the ISCCP, and the community is growing. So with that, now I will hand over to Dr. Anshu Patodia. She's our website in charge, and she is the convener for today's meeting. So over to you, Dr. Anshu, to carry on the further proceedings.
Thank you so much. Thank you, Dr. Aruna and Dr. Bindia ma'am, for giving us this opportunity. We are very proud of the Rajasthan chapter of ISCCP, which was started by Dr. Veena Acharya, and we keep on trying to do activities under the banner. And as a part of it, when Bindia ma'am asked, I was very glad to host and arrange today's webinar. And I will hand over the mic to the MOC today, who is Dr. Apurva Tak. She is a practicing gynecologist. And over to you, Dr. Apurva.
Thank you so much, Anshu ma'am. And I'm deeply grateful to Aruna ma'am, to Bindia ma'am, and to the ever dynamic Anshu ma'am and Ranu ma'am and Veena ma'am, who've given me this opportunity being a gynec oncologist here practicing in Jaipur. So I would just love to introduce the chairpersons for today's webinar. So Dr. Kiran ma'am, she's the teacher of teachers, and we all know her. She's the director professor at the Department of Obs and Gynae at LHMC, Delhi. And she was also the vice president of AOGD in 25-26, and also the past president of the Delhi Menopause Society. And she was the chairperson, secretary for the AOGD, the NARCHI, and ma'am is nonetheless teacher of teachers. The next chairperson for today is the very, very diligent and elegant Sundari ma'am. We all know her. She is the retired professor from MS Ramaiah Medical College, and she's been a very active member ever since. We've been learning from her webinars, from her panels. I remember during my MCH course, ma'am needs no further introduction. And the next chairperson for today is the very lovely, beautiful, and very dynamic Veena ma'am. And she's also been awarded with the Chikitsa Vibhushan. And I'm very glad to introduce that ma'am had also convened the World Congress NARCHICON this year at Jaipur, which was a phenomenal success. Ever since then, she has been conducting so many World Congresses. Last year, in 2016 also, ma'am had conducted. And ma'am has a vast experience in every field of gynae, you just name it. So ma'am is the mentor and the teacher for, I feel, every branch that has originated out of obs and gynae. So with all this introduction, I'll call upon my chairpersons to kindly introduce our speaker. Thank you, ma'am.
Am I audible, Dr. Veena? Yeah.
Yes, ma'am.
You will be Yeah, I will start.
Yes, ma'am.
Okay, wonderful. Very good evening to everyone. It is truly the privilege to be the part of this monthly ISSCP initiative, a platform that beautifully meant for the teachings, for education, for the service, and the main motto is the elimination of the cervical cancer. Today's topic is really so much exciting. The management of the tailoring, the fertility consciousness and treatment touches the one of the most interesting or very delicate interaction of the modern gynecology, preserving the women fertility while ensuring the oncology safety. It is reminding that our decision, whatever we talk today and whatever we have the decisions, that will definitely give the idea of the so many participants the management in the future and the hope for the motherhood. So today topic is very, and our speaker is Dr. Ranu Patni. She's wonderful speaker, and I warmly compliment ISSB leadership under Dr. Aruna Nigam for the sustain this monthly academic exchange, which have become the truly learning continues for the clinician across the country. My compliment also to Dr. Ranu Patni for discussing such a wonderful topic. I request Dr. Kiran to introduce Dr. Ranu Patni. Kiran Agara, please, if you can introduce Dr.
Yes, thank you, ma'am.
Yeah.
It's my privilege to introduce Dr. Anu Patni for this exciting lecture. And Dr. Anu Patni needs no introduction. She's been trained at Tata Memorial Hospital and she's a senior consultant gynae oncologist and at Mahatma Gandhi University of Medical Sciences, Jaipur, and has a vast experience of more than 20 years as a practicing gynae oncologist. She has been the editor-in-chief for Journal for Midlife, which is a meritorious journal of the Indian Menopause Society, and founder-president of the state chapter of AGOI, and she is also the executive member, had been of the Gynae Oncologists Association of India. So I think a long number of credits to her. So we are waiting to hear for a very, very interesting topic.
Yeah.
Like fertility issues, I think the younger ones, like when we are treating CIN1 and 2 and AIS, I think the fertility issues should be counseled, informed consent should be taken, which somehow we forget probably in the this thing track of treating the patient. So over to Dr. Anu for her deliberations. Thank you.
Thank you so much for the kind introduction. Actually, I must share that this is a topic which is not very, I don't think many of us are well versed with. And I too had to look up the literature a lot, but couldn't find. Is my slide visible to all?
Yeah, it is visible.
Actually,
Full screen.
yeah.
It's
okay. Ma'am, ये कैसे बोल?
It is okay.
I can't see.
It is visible, but it's not on the slideshow mode.
It's now it's
Please
there.
make it
Yeah,
slideshow.
now
Yeah,
it's there.
Yeah.
now it's a slideshow.
So the topic is CIN23 or AIS in young women, how to tailor fertility conscious treatment. We have been talking a lot about fertility sparing management of cancers, gynecological cancers, but in pre-malignant conditions, this is something new. We all know that cervical cancer is a global public health problem, especially in the low and middle income countries. WHO has given us a big target. We are nowhere near achieving it by 2030. Statistical calculations show that it might take another 100 years to reach that target. So we have to decide how to move forward, but efforts should not stop. So since time immemorial or long back, we have been screening with cytology and managing abnormal cytological reports. Many studies have shown that abnormal cytological reports are evenly distributed among high-grade lesions, low-grade lesions, and even ascus in lesions which are biopsy proven to be high-grade squamous intraepithelial lesions. So cytology might not be very kind of, might not pinpoint the high-grade lesions that we need to talk about when we talk of fertility preservation. Meanwhile, WHO has given us strategy for cervical cancer prevention, screen and treat, or screen triage and treat for general population, and screen triage and treat for HIV population. HIV population is very important now as far as prevention or management of precancerous lesions is concerned. So now a word about what are the types of CIN. We are going to talk about CIN 2-3 today. So based on cancer risk, CIN is divided into either low grade. Now we talk only about low grade intraepithelial lesions or high grade lesions. So low grade includes L cells, formerly called CIN1, and P16 negative CIN2. High grade lesions are H cells, formerly called CIN3, and P16 positive CIN2. Spontaneous regression is very high in CIN1, so these lesions you can just observe them. In the absence of excision, progression in CIN3 is to the tune of 5 to 22%. So you have to pay attention to management of these lesions very meticulously. We all know that etiology of high-grade lesions is mostly high-risk HPV subtypes, and almost 50 to 60% of all H cells are because of subtypes 16 and 18. As far as pathophysiology is concerned, viral E6 protein, E7 protein, they bind to P53 retinoblastoma proteins, and they are tumor suppressor proteins which induce either degradation of cells or lead to cell cycle progression. Viral E7 function ultimately triggers upregulation of CDKN2, a tumor suppressor gene, causing marked accumulation of overexpression of P16, and extracellular E7 affects endothelial cells by increasing production of IL-6 and IL-8, which promote progression to invasive carcinoma. What are the features of high-grade lesions? We all know CIN2. CIN3 is marked full thickness atypia, loss of maturation, carries high risk of progression, we all know. P16 is diffuse and strong nuclear and cytoplasmic reactivity, block type staining. Just a picture of CIN2, even if it doesn't invade the whole thickness, if P16 staining is strong, it is a high-grade lesion, and CIN3, of course, is a high-grade lesion. So as talked earlier also, CIN2 shows high spontaneous regression rate, 42 and 50% at 12 and 24 months respectively, particularly in young women. And CIN2 progression risk to 3 or worse increases with time. So it can be as low as 5% at 3 months to 24% at 36 months. That is why we have to follow for a longer period. CIN3 confers highest risk of progression to invasive squamous cell carcinoma, up to 31% if untreated, and lowest rate of regression. Also, risk of HCL after 2 consecutive high-risk HPV positive tests is 17% and increases to 41% with 2 previous HPV 16 plus tests. So HPV 16 is that important. P16 we have already talked about. It is very important in the following context: distinguishes HCL from mimickers like atrophy, immature metaplasia, distinguishes morphologically equivocal LCL or CIN1 versus CIN2, professional disagreement on diagnosis when HCL is in consideration, and biopsy if it shows less than or equal to LCL in patients at high risk for missed HCL based. So any discordance, P16 can come to our aid. There are other markers like Ki67. BAG3 is a promising marker now with expression shown to directly correlate with the degree of dysplasia. So there are various risk factors apart from HPV infection. and early onset of sexual activity and multiple partners that we have been talking about, there are a number of risk factors which can lead to CIN development. And we need to know about all of them because we need to catch the lesion early. So if we know high-risk cases, we can catch the lesion early, like in the CIN1 stage, and then maybe follow it up to see whether it persists or it doesn't. So basically, risk factors for CIN development should be well known to all of us: immunocompromised conditions, cigarette smoking, long-term OC pills, low socioeconomic status, etc., previous history of dysplasia or cervical cancer, poor genital hygiene, lack of screening. That is another very important risk factor. If she has never had any screening before, then that is a risk factor. Then even now microbiomes are being implicated in the are being implicated in origin of pre-malignant conditions. So co-infections with other sexually transmitted pathogens such as chlamydia, herpes, etc. As far as treatment recommendations are concerned, treatment generally recommended for CIN 2 or 3 unspecified HCl except during pregnancy. During pregnancy, you have to do a biopsy or treat only when there is a very strong suspicion of invasion. Otherwise, you can defer it till the postpartum period. Or in patients less than 25 years with CIN2, you have to follow with colposcopy and cytology at 6 months interval, and this is preferred over excision. Surgical excision is the treatment of choice except during pregnancy or CIN2 in females less than 25 years old, like I just mentioned. And this treatment potentially increases the risk of second trimester miscarriage and preterm birth, according to various Cochrane databases. So how do we treat the pre-invasive lesions? We all know excisional can be lead-led cone biopsy or hysterectomy in AIS. Ablative can be cryo, thermal ablation, or laser ablation. So what are the effectiveness and limitations of these traditional treatments? Cryotherapy, which is a widely used destructive technique, has shown cure rates for CIN3 ranging from 77 to 93%. But the variability is vast, so we cannot predict how much it is going to be effective. A Cochrane meta-analysis indicated a lower treatment success rate for CIN3 with cryotherapy than with thermal coagulation, underscoring the importance of selecting the most appropriate method based on individual case. So you have to tailor the ablative treatment also according to the patient's needs. So what difficulties do we expect with traditional treatment? With ablative treatments, it can be incomplete eradication of abnormal tissue, and you need meticulous follow-up to know whether because we do not have any margins of the excised tissue specimen, so we can just follow it up to know whether there is any residual lesion that is remaining. So we might have removed incomplete abnormal tissue. That is the limitation or difficulty which we can face with ablative treatments. With excisional treatments, there is risk of harming normal tissue. So you should not over remove the tissue also. Although you have to remove the complete transformation zone, but you can risk and harm the normal tissue, which can impact future fertility and obstetric outcomes. So this has to be kept in mind when you do excision treatments. Both these treatments are dependent on patient-specific factors such as age, parity, HPV status, and previous treatments. So we have to plan the treatment very meticulously, which might not be possible for all of us who have, some of us have very, very busy OPDs or work in rural settings. So these are all dependents on various factors, and treatment has to be individualized. Then long-term follow-up with adequate strategies are also needed. So these are the various types of conization or cone biopsy, leaf biopsy, cone biopsy. I'm not going to go into details of all these. This is a picture depicting the removal of the cone. Very, very important. I will come to that later also. Internal os has to be preserved as far as possible for preservation of for good future obstetric outcomes mostly. So that has to be kept in mind. So what can be the complications when you do excisional treatment? It can be bleeding or infection, we all know, and these have to be controlled during the procedure or after the procedure. But the important complications from the point of view of fertility and obstetric outcomes are cervical stenosis and insufficiency, or preterm delivery or perinatal morbidity. So when we talk of cervical stenosis and cervical insufficiency, these are usually late complications, but they should be cervical stenosis and insufficiency should be evaluated post-operatively, especially if aggressive cauterization was performed or a deep cervical cone specimen was obtained. Sometimes the lesion is high up and you have to take a deep cone. In that case, you remove tissue which is more than friendly for future fertility and obstetric outcomes. So you have to diagnose it there and then, so you can kind of plan future obstetric outcomes better. Cervical stenosis can be treated with dilatation of the endocervical canal, and it is more common in postmenopausal women. So it is again a challenge, but here we are talking about younger women. So we maybe, cervical stenosis we will not face as much as we do with postmenopausal women. But in case of aggressive cauterization, you have to keep in mind that you might need to dilate the cervix post-operatively. As far as preterm delivery and perinatal mortality are concerned, not many randomized controlled trials exist, but most studies indicate that CKC procedure is associated with a greater risk of preterm delivery and intraamniotic infection than the LEAP because of greater depth of excision. So one study has found that conization depths of more than or equal to 18 millimeter increase the risk for early onset neonatal sepsis and intraamniotic infections. Other studies also found that increased conization length was associated with a higher incidence of preterm labor. This might be due to disturbance of the internal os, and then we have to plan cerclage or whatever, obstetric measures to reduce this. So undergoing more conization procedures is also linked to an increased risk of preterm birth. Therefore, limiting the amount of excised cervical tissue is especially important for patients with future pregnancy plans. So conizations should be limited as far as possible. You plan the first conization in the best way possible. And if reconization has to be done, you have to be very careful and counsel the patients for future. Now, as far as the technique is concerned, technique of the excision biopsy is concerned, for the conization, a saw cutting technique is used to excise the cervical cone, carefully including the entire cervical lesion and transformation zone within the circumferential incision, and at the same time, taking a measurable depth out. Counter traction can be provided with toothed or Alice forceps, elevating the cone bed while cautioning not to damage the endothelium. Sorry, this is endothelium, either the epithelium or even the endothelium as much as possible. So we have to preserve the internal os and a little bit of endothelial tissue if possible when you do the, although this might not practically always be possible, but yes, we have to keep in mind. The base of the cone is best excised with Mayo scissors, because you should not, again, using electrocautery at the base of the cone might lead to some lateral damage to the upper endothelium and the internal os. The remainder of the endocervical canal may then be sharply curated due to the benefit of detecting residual pathology. So you have to do this to find whether there is any limit. We all know this. Now, what is the clinical significance? We can do fertility preservation and be cautious about the future fertility, but we have also to keep in mind the risk of recurrence of CIN2-3 after CKC, and this varies by various factors, but on an average it is not much. It is only 1.4%. Positive margin status is associated with higher recurrence rates, we all know, and intercourse, this is also important. Intercourse and or the use of vaginal tampons or gynecological examinations during the early healing period may cause significant bleeding and infections, and these are best restricted for at least 4 to 6 weeks, giving it a time to heal properly, because we do not want to cause any post-operative infections. Now, vaccination has also been shown to protect from recurrent disease, and the vaccination against HPV was associated with a marked decrease in recurrent or persistent HCL. Because in younger women, any recurrence or persistent disease, we will not be able to do justice to fertility preservation or maybe compromise the obstetric outcomes also. This is just to show that follow-up can be done at 12 months with HPV test rather than 6 months to avoid over testing. So now, as far as we have done, we have taken precautions to preserve fertility and good obstetric outcomes. We have taken cautious precautions for during the procedure. Now, during follow-up, individuals with HPV infection should be referred for colposcopy, and the prevalence of HPV persistent decreases over time from 14 to 50 at 6 months after conization to 2 to 22%. So this is much less at 12 months. That is why we do not need, now it is suggested that you do HPV test after conization at 12 months only. And so just to summarize the steps to enhance future good fertility outcomes, adequate preoperative evaluation should be done. Sterile precautions should be observed during peri and intra-op period. Assessment of optimum procedure and amount of tissue removal is very important, like I told you earlier. Avoiding damage to internal os as far as possible. Use scissors at base of cone preferably. Adopt proper technique to avoid surgical complications, because if you go too high, damage the bladder or damage the vessels, you will not be able to give her a good fertility or obstetric outcome later, because you will have to do some excess tissue removal or suturing or embolization or whatever. So avoid over-cauterization and early treatment of stenosis, if any. Proper histopathological assessment of margins is very essential, because margin positivity or negativity will decide the future risk of recurrence and persistence. Adequate follow-up as per guidelines. Coordinated teamwork with your anesthetist, with your minor OT team, with your nursing staff, with your pathologist to enhance outcomes is very essential. And thorough counseling of the patient, last but not the least. Unless you counsel, she will never know what you are planning to achieve and what best, because these are not fertility preservation. Sometimes you may have to deviate from the standard treatment, and the patient can later on question that. So you have to counsel her beforehand. So there, keeping in mind some limitations and problems which we can encounter with the traditional treatments, there have been certain advancements in CIN management, and these can be I will just talk in very brief about each of them. So let us go ahead. These are emerging technologies for CIN detection and diagnosis, which can be minimally invasive or can detect very early. So we all know liquid-based cytology, but now it is known to be as good as only traditional cytology in good hands. Now, molecular biomarkers are coming up, like squamous cell carcinoma A, in various squamous cell cancers, including cervical cancer, offering a potential diagnostic tool for carcinoma, for cervical adenocarcinoma, serum YKL-40, some other novel biomarkers. These might in future might also be applicable to CIN detection. Circulatory microRNAs for facilitating early diagnosis and risk assessment. So these are non-invasive emerging technology. Artificial intelligence, we all know, is now being used in CIN diagnosis, and the accuracy levels are in various studies are ranging from 67 to 98.27%, but we do need to better chart out the AI algorithms and explore chronological changes in abnormal colposcopy findings, and then enhance the predictive capabilities of AI in histopathological diagnosis. So a lot still needs to be done, but yes, it can be a thing of the future. Thermal ablation, we all know, it is not a thing of the future now. We are all doing it, and various techniques are used, like radio frequency, microwave ablation, etc. And it is a feasible alternative to cryotherapy, as it uses lightweight portable electrical generators. So we do not have to carry gas and the big machines everywhere. Overall cure rates are very good, and they effectively destroy tumors while minimizing the invasiveness associated with traditional surgical procedures. Laser therapy is coming up. Photodynamic therapy is coming up. Laser is expensive, not available at many places. Photodynamic therapy employs photosensitizer drugs activated by specific wavelengths of light to induce cell death in targeted tissues. And so basically, they result in direct cytotoxic effects on tumor cells, vascular damage to tumors, and the initiation of an inflammatory reaction that may prompt the immune system to target tumor cells. So this can come up. Immunotherapy approaches can be, we already know about HPV vaccination. Now, immune checkpoint inhibitors, pembrolizumab, is now used in upfront in cervical, has been approved by FDA for cervical cancer treatment. So, combining PD-1 and PD-L1 inhibitors with various immunotherapies or biotherapies has shown promise in augmenting treatment outcomes. Innovative approaches such as DNA vaccines, RNA-based vaccines, and protein-based vaccines, and engineered T-cell therapy are under exploration to amplify immune system's response against HPV-associated cancer. Some other immune checkpoints are also being studied. So maybe in future, we can have immune checkpoint inhibitors along with vaccines, and of course therapeutic vaccines, we all know, are being studied in clinical trials which have demonstrated notable immune response, such as E7 specific cytotoxic T lymphocyte response and HPV specific IFN gamma associated T cell responses. Reported efficacy rates for these vaccines in regressing CIN2-3 lesions to either no CIN or CIN1 range from 17 to 59%, but trials are ongoing. And immunotherapy approaches encompassing therapeutic vaccines and immune checkpoint inhibitors present novel pathways for managing CIN, showing potential in bolstering immune responses against HPV antigen and enhancing treatment outcomes for individuals with cervical neoplasia. So we have to wait and see. These are various therapeutic vaccine trials, some completed, some terminated, and some active but not recruiting. Well, nutrition and lifestyle interventions in CIN management are important. The integration of nutritional considerations and lifestyle modifications is imperative for mitigating the risk of cervical cancer progression and enhancing patient outcomes. Factors such as alcohol and smoking have been linked to increased risk, and all good nutrients are risk, maybe act as they augment the treatment efficacy. So actually, a word about the role of medical therapies in the management, because we want to move from invasive to, less invasive to maybe non-invasive therapies. So this is, we all know, I've talked about the side effects of excision therapy. Hence, there is an increased interest in the use of chemical topical agents. And topical therapies can play an important role in secondary prevention by safely treating precancerous lesions, especially in young women where the preservation of fertility is the main goal. Reproductive outcomes and recurrence frequency must be evaluated after targeted personalized treatments. So various options have been evaluated, but they still require validation, a risk stratification of the patients, and a strict follow-up are needed. So these are the various topical agents. We can't go into everyone's detail, but we have been using 5-fluorouracil and imiquimod, and even lot of antiviral therapies like Immunovir, Sidorfovir, etc. But all these studies I found had very few number of patients. So we have to have some large studies. There was one on polyphenol E with 503 patients, which did not show any major side effects. So these have to be studied, and maybe we will have some good topical agents for treating CINs in the future. Now, still after everything, there are certain challenges that remain in CIN management. The first is refining the criteria for selecting women for various management. As of today, future, we do not know what it will hold for various management strategies, particularly in cases where observation or conservative management is contemplated. We have to establish consensus in clinical practice, augmenting knowledge concerning CIN2's natural history, fine-tuning selection criteria for management strategies, and devising personalized treatment approaches to ameliorate patient outcomes and mitigate the burden of cervical cancer. So we still go by the screening, FOXY-GCPR screening guidelines. Just a word about adenocarcinoma in situ, since it was in the topic. So it is, we all know about adenocarcinoma in situ. Sometimes cervix might look normal, but we have to do an endocervical examination to find the lesion and diagnose. Initial management is identified, if AIS is identified on a colposcopic biopsy. In the absence of a visible mass concerning for invasive cancer, you have to do a diagnostic excisional procedure to exclude invasive disease and assess extent of disease, as there is a 15% risk of concurrent cancer with a colposcopic biopsy showing AIS. If there is a visible mass, an office cervical biopsy should be performed at the time of examination. Now, AIS arises in the endocervical canal. Cone biopsy may more easily achieve an unfragmented specimen. So it is better to take a cone biopsy when AIS is diagnosed with the desired depth of at least 10 millimeter length. If patients are not desiring future fertility, you can extend this to up to 18 to 20 millimeter. But you have to assess. It is very difficult to preserve fertility in AIS, but yes, this is the criteria given in literature. And endocervical curettage should be done after removing the excisional specimen to evaluate the remaining endocervical canal. And in AIS with negative margins and without invasive disease, simple hysterectomy is
Very ma'am, go, sorry.
who have completed childbearing. So it is acceptable in women desiring fertility to defer hysterectomy if they have undergone an excisional procedure with negative margins and negative ECC, but they must be well counseled on associated risks and willing to follow surveillance guidelines. Follow-up, we all know how we have to do. If HPV results in surveillance are positive, the patient should proceed to hysterectomy once childbearing is complete. So this is just an algorithm for excisional diagnostic excisional procedure with AIS. I just want to highlight here that for patients with AIS with persistently positive margins and in whom for additional excisional procedure is not feasible, you have to counsel that we cannot preserve fertility, and you can do either simple or modified radical hysterectomy, which is acceptable. As I said, we are following. Now, one important thing is that across India, since we are all Indians and we want to eliminate cervical cancer from India, These are 5-year observed survival by age group for cervical cancer across 11 population-based cancer registries for the year 2. And there is a wide variation in overall survival, even age-wise, less than 50, more than 50 across India. This is the latest 40 cancer incidence and mortality across 43 cancer registries in India, which again confirms the same. So we have wide variety. So maybe region-wise strategies have to be planned, and we all have to join hands together to do a very good program to eliminate cervical cancer from our country. Thank you so much. I'm sorry I overshot, but
Thank you so much, Ranu ma'am, for such a comprehensive talk. And I would please request Sundari ma'am to just give her expert opinion on this topic.
First of all, I thank Dr. Aruna and Vindhya for involving me in this webinar. And it was Dr. Ranu, it is very interesting, and you brought out a lot of latest technologies and medications and everything about it. I think few things what we need to, I mean, comprehensive and putting in a nutshell your talk thing. What I want to say is CIN2, if it is there in a lady who is a fertility desired girl, we need to do P16 and Ki67, so that if it is towards the low grade, then probably we don't need to do anything, only we have to observe her and then encourage them. Of course, first thing you mentioned is the counseling. It's very, very important for them, because the treatment what we are giving is deviating from the protocols. So we have to tell them the recurrence or progression chances are very high in them. Explaining that we have to do all the things whatever we can do and encourage them to finish their fertility as soon as possible. That's number one. CIN2, one more thing what we say is the risk categorization is one thing which has been brought in by the ASCCP. We have to risk categorize the woman even with the CIN2. If she is into the risk categorization, probably we can do ablation or cryotherapy depending on the transformation zone type for them. Cone biopsy, probably for CIN2, probably we can avoid it definitely, even if it is transformation zone CIN3. CIN3, probably, yes, we need to give a definitive treatment. As you brought in your talk, the progression is really faster and higher rate of progression is there. So we have to treat them. Probably we treat them with the leap or a cone, depending on again and the type of transformation zone. And AIS is the difficult one. Probably AIS definitely needs a treatment, and that too it is an excisional only, not the ablative procedures for the AIS. Probably we may have to go for either LEAP is also advised now, and then of course otherwise depending on the extent of the lesion. And always AIS treatment, when we are thinking of it, we have to remember about the skip lesions. That's the one
Yes.
thing which can cause a recurrence, high chance of recurrence in these things. I think that's what we have to remember. CIN2, we can follow them up if they don't come into the high risk category, risk categorization, and P16 is negative. And CIN3, definite treatment, but it is a conservative treatment, and AIS, definitely we have to treat. But probably conservation is, though we used to say simple hysterectomy, but now even a cone is at first we say cone. Now even LEAP is also being recommended, but keeping the close surveillance. Most important, as you mentioned, Dr. Ranu, close surveillance of these people are very, very important. Thank you.
And counseling of these patients is absolutely essential.
Yes, very true.
Thank you very much. I will take a leave because I have to leave for the station in some time. So thank you all. Thank you, the organizers, for giving me this.
Dr. Anju, this side, I just want to put one point that in the AIS, we can consider the trachelectomy also to save the fertility in few cases.
Yeah,
Not,
actually,
uh,
I'm
Yes,
sorry to
yes.
interrupt, Dr. Anju.
No. Yeah.
Actually, we are very running short of time.
Yeah.
Please put your queries in the chat box and they'll be aptly answered by Dr. Ranu. Please, I'm really sorry because it is very difficult to in a webinar. Thank you so much. Over to you, Dr. Anshu.
Thank you so much, chairpersons and speaker Dr. Ranu Patni ma'am, for sharing their valuable insights. And I would request Dr. Apurva to introduce our moderator and panelists, because we have a wonderful panel discussion on all the things we have covered. Dr. Apurva.
Yeah,
Yeah.
Dr. Anshu, I think you can make the introductions very
Okay,
brief so
okay,
that we
okay,
can save
ma'am.
the time.
Yeah, so I'll just introduce Dr. Leela ma'am. Everyone knows her. Ma'am has recently shifted to Ashwin specialty. And as panelists, we have, she's my batchmate, Dr. Madhuri. We are together in GMC and she has a special interest in oncology. Next panelist, I'm myself. We have Apurva with us. She's a consultant gynae onco. And then we have a pathologist with us, Dr. Sonali Nayak from Homi Bhabha Cancer Hospital. And obviously everyone knows Dr. Pratibha Singh ma'am. She is department head at AIMS Jodhpur. And I'll stop sharing and hand over to Dr. Leela ma'am.
Yeah, thank you. Yeah, is it visible?
Yes, ma'am.
Yeah, okay. So respected chairpersons and the delegates who have joined virtually, at the outset, I thank Dr. Aruna, Dr. Bindya, and Dr. Anshu for giving me this opportunity to moderate equally challenging session on the glandular lesions. Of course, it has given me an opportunity to read and revise whatever little I have learned in the past. So with a few case scenarios, what I could collect, we are going to have a panel discussion. You can alert me when the time is going to be over 5 minutes before so that we can wind up on time. So yeah, already the team is introduced. So we know that the glandular lesions are definitely different from squamous lesions. We all actually see a lot of squamous lesions and our knowledge with regards to glandular abnormalities is very limited. And this is an opportunity for us given by our president to understand more and more about these glandular abnormalities. Even though we see rarely these smears showing glandular abnormalities, one has to be very careful because sometimes the squamous lesions can be with different grades, lower grade and higher grade. But most of the times glandular abnormalities are a strong association with adenocarcinomas or invasive carcinomas of glandular epithelium. So one should not take the glandular abnormalities in the smear as a very light, and one has to really work hard to do a colposcopy, biopsy, and all these things are challenging, so which we are going to discuss now. So I'll just discuss, stop this slide. I'll skip this slide. Yeah, straight away, let us go to the case scenarios. She's a 43-year para 2 live 2 completed the family. She has regular menstrual cycles. Her mother died of cervical cancer 18 years ago. So she's asymptomatic, but she came for cancer screening because her mother died of cervical cancer. Her examination, everything is normal. Speculum examination of the cervix has shown a huge ectropion, and bimanual pelvic examination was normal. She had a cytology screening, and the cytology report came as atypical glandular cells, not otherwise specified. So I request Dr. Sonali to enlighten us about these glandular abnormalities at the cytology. What is AGC? What is AGC NOS?
Um, Generally, when we see glandular cells, normal glandular cells in a smear, so they appear as loose clusters. When we do a LBC, they appear single cells, or they can come in strips, or they can come in sheets. And they're so nicely placed with they maintain their space, they respect each other's space, and they are very nicely placed. But when there is a proliferation, because of then comes the crowding of cells. So there is crowding, there is cytologic atypia, there is architectural atypia. So here we can see in the first picture the cells have crowded together. They're coming around small gland. They have radially arranged around small glandular structures. And in the first picture itself, towards the right, we can see the cytoplasm feathering around. In the second picture, we can see cells having knuckles. They look like knuckles in the periphery. The cells in the periphery are having some knuckling kind of picture, and the cells are a little bit columnar. The nucleus is little bit elongated. Same it is in third picture. So these are actually the atypical glandular cells. That means there's some proliferation going around, which is creating some cytological abnormality and some glandular abnormality. Now, when we see some AGC, we have to differentiate whether it is coming from the endocervix or whether it is coming from endometrium, because both have glands. Now, if it is endocervix, then we have to write AGC endocervical. From that is coming from the endocervical, and suppose we find it is coming from endometrium, they are more tight clusters. Endometrial ones are very tight. These are clusters which are loose clusters, so they are more probably of endocervix. But when we see some glandular abnormality with, features like hyperchromasia, too much of crowding, overlapping, a few microdisfigures can be seen. In that case, we have to consider writing them atypical glandular cells favor neoplastic. So we are pointing towards neoplastic in those conditions. Because sometimes what happens, because of reactive condition, because of polyps, because of IUDs, a lot of changes happen, but they are not neoplastic. So ideally, we have to, when we see abnormal glandular cells, we have to see whether they are actually reactive conditions or they are malignant. They are neoplastic. So we have to write and categorize them whether it is endocervical or endometrial. In conditions when we are not able to categorize them in all these situations, then we can put a generalized term as they are atypical and we don't know. So it is like an NOS. So gradually, when we have a biopsy in such cases, we can then categorize them.
Okay, so as long as the description is concerned, one has the from cytological point of view, you should be able to tell us whether it is endocervical or endometrial. When you cannot say, then you would say not otherwise specified.
Yes.
Yeah,
Ideally, we should do it. We should categorize it.
Yeah, okay. So usually when we send you a lot of smears, and what is the prevalence of glandular abnormalities in your regular screening or the samples
Very
you
low.
get?
Yeah, it is actually very low. Very recently, we made an audit. Every year, we conduct that cytologic histologic correlation. It comes as a part of an audit of cytological screening. So last year, it was less than even 1%. Usually, these are very low as compared to the famous lesions. Glandular abnormalities are very low. And we found that in our center, it was like 0.7% we got. So it is really very low. Out of, 4,000, this was a thing which we published. Out of 4,000 samples, the prevalence was 0.7. So,
Yeah,
this
the
is like that.
literature,
Yes,
evidence is the similar. It's less than 1%, the
less than
glandular
1.
abnormalities. But one has to be very careful because most of these glandular abnormalities can be associated with either adenocarcinoma in situ or there can be an invasive adenocarcinoma. Not only
Yes,
that, they can even be associated with squamous abnormalities. So you have
yes.
already explained us about what is AGC and OS. And what are the different glandular abnormalities you see in the cytological picture? And do you find it difficult to report from the squamous abnormalities?
The different glandular abnormalities are that I said they are endocervical, atypical glandular cells, endometrial atypical glandular cells, and adenocarcinoma in situ and adenocarcinomas. Adenocarcinomas are very difficult to report on cytology unless we see necrosis, all those conditions. But atypical glandular cells and adenocarcinoma in situ, endocervical adenocarcinoma in situ can be reported. Yes, definitely we can report those. Now, we have certain features. The Bethesda system has given us clear-cut definitions of what is seen. So there will be crowding of glands. They will be more hypochromatic. They will be polar. They all will be perpendicular to the lumen. There will be knuckling. There will be mitotic figures, feathering, fish on end appearance. All those things, if we see, then those are glandular abnormalities. Now, it is difficult in situations where there are overlaps between endocervical, glandular with an head cell. Because the cell size of endocervical cells and the cell size of the parabasal cells where the head cell develops are almost the same. So if I don't, and head cells, they don't have much of cytoplasm. So in that condition, the difference, because of that, it becomes difficult. But still, if we keep on searching for the cytoplasmic feathering, wispy cytoplasm, all those features, no, at least we can say this is glandular. And single cluster might not be, I mean, when we have some abnormality, no, it is not a single cluster which is showing. All the clusters will be showing the same abnormality. Every cluster will show wispy cytoplasm, every cluster will show knuckle ends. So that is how we can differentiate. But yes, HCL is a very, very important differential. And usually when we give endocervical abnormalities, no, then around 10 to 40% of cases, no, on histopathology correlation turn out to be HCL.
Okay.
It is like
Okay.
that.
Yeah, I think it's so from cytological point of view, it is challenging. The same challenge we face as clinicians.
Yeah. And also another thing is that there are, in case of endocervical adenocarcinomas, I mean AIS, there are HCLs involving, when HCL involves the endocervical glands, then it is more difficult. So that is how the differential comes into of HCL.
Yeah, Dr. Pratibha Singh, I don't know whether she's around or not. Is she there? Yes, yeah, okay, Dr. Pratibha. So this lady had only LBC done, but she didn't have any HPV testing. So do you think that she needs HPV testing also? Or can we ignore, I mean, can we omit the HPV testing in this particular patient? Or is it going to be of any use doing a HPV testing?
Dr. Pratibha Singh, ma'am. I saw her name in the list of people.
Okay, otherwise anyone of you, Dr. Anshu or
So,
Yes.
Dr. Apurva, yeah, you can, any one of you can take it.
So ma'am, actually in AGC, atypical glandular cells, which is most important, which all guidelines recommend is that we have to rule out all the areas wherever glandular cells are there. So as was rightly pointed out before also. And so we go ahead with endometrial biopsy and then endocervical curettage as well as the conization procedure. So now invasive procedure. Now HPV testing, if we talk about that, it will be helpful because both ASCCP as well as the WHO guidelines also, they have recommended HPV as a test of cure. Now, depending upon, conditions, they say that you can follow them up with a test of cure at 12 months. And also later on, it will help us to follow up with cytology. You can do a co-testing at 1 year and 2 year. And let's say if this persists or if the HPV abnormal persists, then again, this is an indication that you need to go ahead and act upon.
Yeah, anyway, that is a little controversial with regards to HPV testing. We will discuss later if you have time, because HPV associated, HPV independent adenocarcinomas have a different kind of a prognosis and other things. But as such, when you have a glandular abnormality, whether you do HPV testing or not, but you need to do more than that, definitely. Yeah, what do you consider to do the next, if not HPV, what is to be done?
Ma'am, we have to evaluate AGC with the endocervical curettage, the endometrial biopsy.
No, other, before endocervical curettage, what else has to be done?
To go for a colposcopy, ma'am.
Yeah,
Colposcopy.
colposcopy is a must.
Colposcopy guided biopsy.
Yes, yeah, definitely we need to do colposcopy. Yeah, so of course, this is a FOXY guideline. You have already said that you have to do colposcopy, endocervical biopsy, endometrial sampling, and all these things. This is one of the FOXY recommendations. So for our patient, we have a glandular abnormality in the cytology, and that's why she is subjected to colposcopy. So these are the colposcopy pictures. And as I mentioned earlier, she has got a huge ectropion. And this ectropion, this is after saline and this is after green filter. Actually, they have applied acetic acid, and then after that, they have even seen that through green filter. So these are the pictures. Actually, these are shared by Dr. Vamsi from Homi Baba Cancer Hospital. So I sincerely thank him for giving me this case. So these are the pictures. Dr. Anshu, can you interpret these images?
Yes, ma'am. So as you said, ma'am, large ectropion, we are not able to see one side of the cervix properly, and that is a problem in some patients where the vagina is lax or the patient is like the age is near menopause. But we can, after acetic acid, we can clearly see two large, very acetovite, dense acetovite areas at around 6 o'clock on the posterior lip of cervix and on the anterior lip of cervix, which is encroaching into the endocervical canal. And so I would give it a sweet score of 2 for acetovite, 2 for the opacity, and at least 2 for involving more than 2 quadrants. So definitely a 6. And since iodine is not there, I cannot comment on that. And on green filter, I'm not able to see, I'm able to see a very large center dilated vessel, but no mosaicism or such. So I'll definitely consider it a high grade lesion.
Yeah, actually, the colposcopic interpretation is not so easy as we see in the squamous abnormalities. Here in this picture, we are seeing most of these, the glandular, the villi, fusing of the villi and the clumping and all these glandular openings appear to be very prominent. So like that, we are seeing in this villi prominence, we are seeing here in this particular picture. So yeah, you have already told us.
So this is ma'am the type 1 SCJ, this one.
Yeah, the squamocolumnar junction is type 1, but I don't
Type 1.
know whether the same rules what we follow for the squamous abnormalities
Actually.
are applicable to the glandular abnormalities, but we have to see the rest of the cervix, the transformation zone, to rule out any associated squamous abnormalities. But here we are significantly, the lesion is seen on the endocervical epithelium. So that is very characteristic of the situation, mostly in glandular abnormalities. And persistence of these white changes are very important, because when we apply acetic acid, even when there is an ectropion, transiently it becomes white, but it clears very fast. Whereas when there is a glandular change, it won't disappear. And here in this picture, you could see very thick white clumping of all these villi and other things. I'm going to show you some of the pictures similarly in a glandular abnormality. So what are the challenges you face when you want to do colposcopy in a glandular abnormality, Dr. Anshu? Actually, I have listed out all these things here.
So the main challenge is visualizing the endocervical canal, because when we suspect a glandular abnormality, we really have to go inside the cervical canal to see the, if possible, it is to see the upper extent of the lesion, because that will direct our management on how deep we want to go for the biopsy. So that is the main challenge in endocervical lesions.
Yeah, so you have to look into the endocervical canal, whether the lesion is confined only what you are seeing, whether it is going further into endocervical canal. That is also very, very important. So the colposcopic pictures of the glandular abnormalities are listed here. And we have seen some of these already in our case. We have seen the fused clumped villi. We have seen large gland openings. We have seen white lesions, which are very close to the adjacent to the squamocolumnar junction. So all these things we have seen in our case. And these are some of the pictures which I got from the literature. You could see how thick estovite is there in the glandular epithelium, how this clumping of the villi is happening. And here you are seeing this estoviteness with some abnormal vessels, and actually it is going into the canal also. So these are some of the pictures, and these pictures are shared by Dr. Sundari Madam, her own personal cases. So it appears to be a huge ectropion, but when we applied acetic acid, you could see all these villi so prominently estovite, thickened and other things. Here also you are able to see and the entire lower part of the endocervical epithelium has become very much aceto-white. So thank you, madam, for sharing these pictures. So these are some of the glandular abnormalities. What I wanted to show is it's not very easy to get these kind of cases. So that's why it's better to keep all those cases and keep sharing our knowledge. So that is very, very important. So you have seen, you have done colposcopy, you have found out the abnormality on the endocervical epithelium. So what are the biopsies you like to do, Dr. Anshu, for this lady?
Yes, ma'am. It is because the lesion is involving multiple areas. LEAP would be the ideal way of making sure we have all the information we need. And we can go like, we have to first visualize how deep the lesion is going into the endocervix, and then make sure we get it in one piece. so that we
You want to do a loop excision, or you want to use a loop to take the biopsies?
we want to use a loop to take a biopsy, and so that we get a one piece intact tissue, so that we can have an idea about the margins and whether we are doing a proper, we are getting the upper limit of the lesion.
Yeah, so what I wanted to say here for clarification, whenever we do a squamous lesions, whenever we see, we take Tischler's or ordinary punch biopsy, we take it. But in cases of these glandular abnormalities, it is better to take a excisional biopsy, small loop biopsies. So because the tissue will not be crushed and you will get a proper biopsy report. And as Dr. Apurva has said earlier, we should always take a endocervical curettage, or some people do take an endocervical sampling also, they take using a brush. So endocervical evaluation is very, very important. And of course, there is another technique which I'm going to discuss later if the time permits, to visualize the endocervical epithelium, where your colposcopy is inconclusive, or when the transformation zone is type 3, and you have to really look into endocervical canal, then there is a different technique. If time permits, we'll discuss about that also. Yeah, so you have already said sufficiently large sized biopsy, all these things have to be taken. Now here the role of our pathologist comes again. We have taken the biopsy and we have sent to Dr. Sonali. So can you briefly explain us about this biopsy report, Dr. Sonali?
Yes, ma'am. What happens here is we see glands, but the glands, they generally endospermic glands have a lot of mucin in them. So first, what we see is that these glands have lost mucin. These are mucin depleted. They're more columnar, and the cells are crowded. There's proliferation going on, so they are crowded. Like you can see, yeah, yes, that line. They're all crowded together. The cells are pseudostratified. When they become crowded, no, they appear pseudostratified. Some will go up, some will go down. Mucin is gone. So that is how, and they become hyperchromatic. That is why it is looking more blue. So, and the characteristic feature is that we find mitotic figures apical, jumping, floating mitosis. It is very characteristic where the cytoplasm, the mucin part, no, if you can just scroll down your cursor, in that mucin part, there will be some mitotic figures. So that is called floating jumping mitosis. And in the basal part, we'll find carotid debris. So those are very characteristic for adenocarcinoma in situ. So this is how it is. But I mean, and there will be no desmoplastic reaction around the gland. Suppose I find desmoplastic reaction around the gland, that means the gland is infiltrating inside. So it might have become an adenocarcinoma. But these glands will have normal stroma around them, and will have all these characteristic features like columnar cells, crowding of cells, depleted mucin, jumping, floating mitosis, and basal characteristics. So with this, we will consider these glands are adenocarcinoma in situ. And very important feature is that they are like skip lesions will be there. Like madam said, no, there will be skip lesions within the gland also. In a single gland, in my next picture it will come, in a single gland, part of the gland here. Then the second gland here. Yes, that's a normal gland, but that part, it has become adenocarcinoma, in situ lesion, that dysplastic. The upper part is dysplastic. In the same gland, some part will start becoming dysplastic. Yes, that is the dysplastic one. And the lower down portion is completely normal. So this is abrupt transition will be there. So this is how we, I identify these are all in situ lesions of glandular cells.
Okay, yeah. So you have diagnosed this biopsy as adenocarcinoma in situ. Yeah, okay.
Yes.
So now we have the histology with us. We know the woman's history, 48 years, family completed, and she's very much worried that her mother had cervical cancer, and her biopsy also has come as adenocarcinoma in situ. And even she had an endocervical curettage. Whatever curettage they have done, it did not show any abnormality. Probably, I'm not sure whether it is confined only to that part, but it is anyway adenocarcinoma in situ. That whether it is only confined to one part, or whether she has a skip lesions and other things. But now the histopathology report is with us. So how are we going to manage this lady, Dr. Apurva?
Yes, ma'am. So particularly in this case, considering that she has completed her family, very important in adenocarcinoma in situ is just because she's just undergone a simple biopsy, we need to do a excision procedure. So one principle that has to be taken into mind, that we have to do a excision procedure in the form of a leap, a type 3 leap, which we say, in which we can go up to 18 to 20 within the endocervical canal, because she's not needing to preserve her fertility. In cases rather where even fertility sparing is indicated, they say that up to 10 at least, you should take a cylindrical excision. And because, the important thing here is that there are chances of having skip lesions. And after taking the cylindrical excision also, you have to do a endocervical curettage. So with this, you will actually know that the margins of whatever you obtained, whether they are free or not, because the margins are going to tell you that in case the margin is positive, you may need a further excision of cones to rule out any invasive cancer, because then the entire modality of treatment is changing. So what I have been seeing here is, if at all patients from periphery, even if they're diagnosed with AIS, ma'am, they would simply do a hysterectomy. So no, hysterectomy is not the management for AIS, and fertility is complete. It has to be a cylindrical excision, and cylindrical excision or cone, because we do not want a fragmented specimen. That is what is important. So it's not that you take a simple small excision and then you do a top hat. That won't help. So either it has
Yes.
to be a good 18 to 20 cylindrical excision, or you go ahead with a cold knife conization. So any of
Yeah.
these can be done.
Yeah, so as you have rightly said, there should be adequate length of the cervical canal has to be taken out to rule out the skip lesions, and of course, it should not be a fragmented specimen. So, do you prefer using a loop, or you prefer a cold knife conization?
We have this, since I have joined this institute as a gynae onco, I have, the first thing I did was purchased a colposcopy and established a colposcopy clinic. And we've got those cone loops also, because we've got a new set. And yes, what I've been doing is, ma'am, taking the large chunks, the leap procedure. That's what I'm doing.
Okay, so you have done the cone and the specimen has come out and the margins are all free. So what do you advise her? You still okay to follow her up, or you advise her hysterectomy after your cone excision?
So, ma'am, if the cone excision says that the margins are free and she's also not willing to preserve fertility, as in this case, so definitely she has to undergo hysterectomy. Now, why? Because unlike squamous lesions, particularly these lesions are prone to have skin mets and prone to have recurrences thrice as more common than the squamous lesions. So there is no point in subjecting her to all these follow-ups to all these conservative approaches. So when margins are free, he can straight away go with hysterectomy.
Yeah. Yeah, so you have nicely covered all about these principles of management of CGIN and other things. Even Dr. Rani Patnu also has told us about the conservative management in cases of fertility, and all those things we have already dealt with. Yeah, you have even elaborated the risk of residual CGIN and development of invasive cancer. So with the positive margins, definitely the risk of subsequent invasive cancer is significant. Even with the negative margins, we do see some percentage of invasive cancer risk. So that's why you have rightly said, once the family is completed, even if the margins are free, it's better to go for a hysterectomy. Which type of hysterectomy you prefer in this case? Yeah, yes, with margins free.
Ma'am, this has to be a simple hysterectomy. Now, rather with coming of shape trial also, they are saying even in microscopic CA cervix also, you can go ahead with this. But as of now, with my practice in malignancies, I'm going with radical. But for this case, definitely margins are free and it's an in situ cancer. She can go ahead with simple hysterectomy type.
Yes, yeah, you are right. You are correct. Yes. Yeah, so suppose you have done a cone in a woman who is desirous of fertility, and how do you follow her up?
So, ma'am, when we do a cone, or a type 3 excision of the transformation zone, so they say we have to take at least 10 deep and you have to do a ECC. Now, when everything comes out to be normal and negative, then I would follow her up, aggressively at 6 months and 18 months with the HPV, as well as we need to remember to take a endocervical brush cytology. So we were always taught during our MCH course, Berman sir used to always teach us to take endocervical curettage and these cervical cytologies very nicely. So we always have this practice to take these lesions, the biopsy, endocervix.
Thank you. Thank you. Do we still have time, Dr. Bindya? Yeah.
Yeah, ma'am.
Yeah. Do we still have time? Then
We have to wind out in next 5 minutes, madam.
Okay. So I'll just, yes, I think most of the points what we wanted to discuss, we have discussed in the first case itself. Just for, yeah, a small scenario, just to talk about endocervicoscopy. I have put this scenario. She's a 33-year-old para 1 live one. She had LSCS delivery. Her LBC also came as atypical glandular cells. She actually had a co-testing. HPV 16 was positive. She was sent for a colposcopy and that was normal. That means they could not see any lesions on the ectocervix or on the transformation zone. And of course, because of her cesarean delivery, even the transformation zone was not very, very clear. So in these situations, when you are not, your colposcopy is inconclusive or you are not able to see any lesions on the cervix, how do you rule out endocervical pathology? Because the lesion can be somewhere in the endocervical canal also, which you are not able to see at your colposcopy. So Dr. Madhuri, what would you do in these kind of situations?
Yes, ma'am. She's 33 years old, paraben living one. So, and her atypical glandular cells she's having an 16 positive. So, we can have endocervical curettage and endometrial biopsy simultaneously because to know the origin of atypical glandular cells. But in endocervical curettage, most of the time we might miss the site from where if there is pathology, because the pathology might lies in the endocervical canal. So we have a procedure to do, that is endocervicoscopy, and usually we are accustomed to hysteroscope, and nowadays we are using Bertolucci 2.9 millimeter scope with 4 millimeter diagnostic sheath. So we can visualize the whole endocervical canal with this 2.9 millimeter scope, and this procedure is called endocervicoscopy, and similar with the same scope we can visualize the endometrial cavity also. And this procedure is done as a office procedure, but usually we are keeping the scope in the OT, so we are doing it in the operation theater. The procedure is two-step. Can I just elaborate, ma'am, or if we have time?
Because lack of
Yeah,
time,
yeah.
you can just
We
briefly
can we
explain.
can go ahead with the vaginoscopy, the distension media. We can use normal saline. After vaginoscopy, we can visualize the ectocervix completely. Then we can introduce. We can go in the endocervical canal and visualize the endocervical canal, whether there is any lesion or any polyp that till internal loss. This will be endocervicoscopy, and simultaneously we can visualize the endometrial cavity also. This was first step. And in the second step, what we do, 5% acetic acid with this in the syringe, we push into the endocervical canal, and then after that again we reintroduce the scope to visualize the endocervical canal to see the whether there are any acetovite lesion inside, and from that site we can take direct biopsy. And
Yeah.
similarly, yeah, and already we have done, this is two step. And actually, can I add, ma'am, some people, they have added micro colposcopy with this procedure, with this 2.9 millimeter Bertolucci, and in that case they have used this blue dye, Waterman's blue dye, which stains the cells, metaplastic cells. And with this dye, and with magnification of this 2.9 millimeter scope, we can see the even the SCJ in the endocervical canal, good outline of the SCJ, and if there are any cellular abnormalities, this is called as microcolposcopy. So it can also be added with the cervicoscopy in this patient.
Yeah, so these endocervicoscopy pictures are, some of the pictures are shown here. So this will give us an idea, as you have explained nicely, about looking into the endocervical canal using our office hysteroscope and doing acetic acid application, and then taking the directed biopsies, which has got a very good negative predictive value. This is an Indian study where they found a positive predictive value of 33%, but it has got a high negative predictive value. So yeah. So I think, yeah, I'll just show the pictures because lack of time. So this is another case. She's an elderly lady with post-menopausal bleeding with a HSIL smear. She is referred to us for colposcopy. When I have put the scope, I could see the cervix, which is very much bigger for her menopausal status. And she has got a lesion on the cervical os like this, which is highly vascular. And we have taken a biopsy from this lesion after application of acetic acid and other things. It came as adenocarcinoma in situ. And of course, she is only partly evaluated by me because she's referred for colposcopy. But definitely she needs evaluation for her postmenopausal bleeding as her her transvaginal scan has shown increased endometrial thickness. So with this colposcopy report, I referred her back to her primary physician to look into the endometrial cavity also to see whether the lesion is higher and coming down or both are independent or both are the same. So that is just for the picture's sake, I have put it. Yes. Yeah, okay. For the lack of time, I'll skip the case. So just a take home message, it's always a challenge as we have discussed. And we do pap smears, we need to do colposcopies, and we need to practice doing these things more and more. And probably we should look into the endocervical canal also whenever we are doing colposcopy for practice case sake. And of course, planning a proper biopsy, planning a proper treatment, all these things are very, very important for us. And fertility issue is again an important thing when you are looking into the glandular abnormalities, which we have already discussed. So with this, I thank my panel for being very interactive and nicely conveying the messages. And thank you very much. Thank you, the team, for giving us this opportunity.
Thank you so much. Thank you, ma'am. And it was a wonderful panel. And like I had talked to Dr. Ranu Patni and Dr. Leela ma'am, that we have been given a very tough topic. But I believe we have been able to do justice to the topic. And with that, I would conclude today's webinar and thank Dr. Aruna Nigam and Dr. Bindya ma'am for giving us this opportunity to discuss such a difficult scenario and unusual case scenario. Thank you so much, everyone.
Thank you.
Thank you.
Thank you,
Thank you,
Dr.
Anshu, for leading
Thank you,
the
Dr. Bindya and Dr. Aruna Nigam, for wonderful webinar today. It is such a eye-opening, and I'm sitting from last day, and Dr. Leela Murthy is conducting such a wonderful
Thank you, madam.
discussion. I don't want to cut off the things, but it is very eye-opening, and more than 100 people are waiting for your talks, and that is really, Dr. Leela, it's really very good because
Thank you, madam.
interaction
Thank you. With all your
interaction is
blessings.
really required for the discussion, because
Yeah,
panel discussion is really giving so many things to discuss. And I think that is very important, Bindia, to have a panel discussion
Yes,
more time.
have it with
I think it is
everyone.
more time required for the panel discussion because
Yes.
each participant is required so many discussions, so many things to discuss. Thank you so much, Bindia and Aruna, for involving me. Thank you so much.
Thank you so much, esteemed panelists and faculty for bringing so much importance for this webinar today. And it was such a difficult topic, very well conducted and great justice to the topic done. And thank you, Veena ma'am, for your blessings. And we have always had more than 110 delegates in each and every seminar. Webinar for the last months we've been conducting, 6 months almost. So it's your blessings and the goodwill that the ISCCP holds, which attracts everyone, and we have very good topics every time. So next month, 7th November, 7 p.m., 70 minutes, let's spend some time for a very interesting topic again. It is on Win and Wane, the precancerous puzzle of the lower genital tract. So till then, we wish from ISCCP a very, very happy Diwali to all the listeners and wish you a very colorful, all this month celebration. So from us, greetings to all, and thank you very much for this interesting webinar.
Thank you, Dr.
Bindya
Bindya,
ma'am.
Dr. Arya. Thank you,
Dr.
Dr. Anshu.
Aruna.
Yeah, it was very good.
Thank you.
Thank you.
Thank you
Thank
for
you.
the opportunity.
Beautifully done, Leela, as usual.
Thank you, Manu. Thank you. Because we were having this kind of discussions in the previous classes also. So I saved all the PPTs what I got from other. Yeah, I think Dr. Bindya probably we can do a lot of things as a teaching material also.
Leela, every time the new fellow are attending, every time the new participants are attending, so they are the new things for them also to discuss, to implement their in the day-to-day practice.
Yes,
Very
Veena,
good.
that is why we have kept a lot of different variety. We don't
Yeah.
repeat, like after cervix, we have vaginal vulva. Then after that, we had glandular this time. Previously, we had adolescents. So
Yeah.
on population, Dr. Nilanjali had the panel on HIV, transplant recipients, and
Yeah,
also what we have in our mind is we are getting out different scenarios and topics for the webinar. So that is one challenge. So we have many more coming up on treatment as well as on other aspects, even vaccination all will be touching. So we have some time to.
Vidya, I'm so happy and I must congratulate you and Dr. Nigam because the ISSB is growing like that. I'm so happy to see all the things. It's great.
Directions.
Actually, the USP is that all the topics are very clinical. So
Yeah.
that is the best part. That is why many people are joining also to clarify their clinical doubts.
That's why I told you more time is required for the discussion.
I'm thankful to all the ICCP executives who are taking initiative to hold at least one of these webinars so that it is from all the corners of the India.
Yeah,
So we
that's
need
right.
to have contributions from all the ICCP members in all the activities so that we can grow together.
Yeah.
Thank you all for
you.
joining.
Thank you.
Good night.
Thank you, ma'am.
Good night.
Bye. Good night.
Good night.